para saludar a través de Skype. Simplemente saludos y vamos a
connected to
ver si
this room
esto rápido
through
y
Skype. I'm gonna be brief. I hope this will be straightforward. So I'd like to thank the organization for inviting me to talk about this very interesting and hot topic, ultrasound in massive pulmonary embolism. I started to work on this topic 20 years ago. There was only a few of us who devoted our time to this topic. So everywhere we went, we talked about what we knew and everybody was happy. But the situation has changed because now many doctors are aware of this new technique or this technique. But I still have the habit of talking about very few and precise things. The use of ultrasounds in massive pulmonary embolism and for the diagnosis, the significance, the quality and the safety of this technique focused on this type of diseases and how it is different from the ultrasounds used by heart doctors. And for the massive pulmonary thromboembolism in the ICUs or the emergency rooms. Ultrasounds now are some of the first steps in every algorithm in order to evaluate pulmonary embolism. It is now one of the main techniques, and it is well before or well ahead other techniques. So if a patient is hemodynamically stable, ultrasounds are the first step. But for the diagnosis of pulmonary embolism, ultrasound is not the first choice technique because the specificity and sensitivity levels are not perfect and are not better than the angio-CT, because the levels of specificity and sensitivity of the angio-CT are better. But we have to use ultrasounds when patients cannot get access to an angio-CT for whatever reason, because of their hemodynamic state or because it is not available. But for diagnosis, ultrasounds can be useful. The evolution. Sorry, I need to wear this headset. I think I have two microphones. So in the evolution of the diagnostic evaluation of the tissues, we see that in the first step we see a congestion of the blood of the minor circulation. The small vessels are closed. And this is, of course, adequate for ultrasounds, because ultrasounds love this. They love the liquids, and when liquids become solid tissues. So it is all the better. So these tissue changes are favorable to use evaluation both at an early stage. We can see hypoechogenic images that represent the pulmonary congestion, and also on the late stage, the consolidation, hyper and isoechogenic images that show us the evolution towards an infarctus. This cannot compete, of course, with the crystal clear image of an angio-CT. We can even see the obstructed vessel and all the secondary vessels. But this paper, published by Kossel in 1991, showed that pulmonary angiography is well better, because it can even show the subsegmental arteries. The echo can only detect problems on the arterials pulmonaris, but when we use a combination of both, we can even see, with the thorax sonography, we can see the segmental arteries. So we combine the ECHO with the thorax sonography, we can get most, we can go very deep. We cannot cover just the segmental, the pulmonary artery, sorry. So you can see here this cross-sectional image of the lung, and we can see the pleural surface, and here we can see this triangle cavity. This is a characteristic of the pulmonary infarctus, and we can see this vortex, which is also a main feature of the infarctus, and a hyperechogenic image, which is a trapped bronchiole. So it is useful for the diagnosis, but the patients, when we see them, they don't have a diagnosis, they have a problem, they have a condition, and they can be asymptomatic, or they can even have a heart arrest. And even if they have a pulmonary embolism, they can be asymptomatic. We've seen this in this paper in 2010. Out of 5,233 patients, 32% of them had a deep venous thrombosis, but they were completely asymptomatic, and they had embolism. So the percentage of these patients that have this massive form of instability and a severe hemodynamic stability is quite large. The PIOPID group collected data for 5 years, and they saw that dyspnea is the main symptom, 73%, and then pleuritic chest pain, and then hemoptysis, but only 13%. And the circulatory collapse was 8%. This is the sign, and this is good for echography, for ultrasound. We've known this for 25 years. Since 1991, we know that ultrasound is good for making decisions in case of respiratory distress or chest pain, hypertension, shock, or cardiac arrest. We know it is unquestionable. So, if the two most common ways of symptoms are favorable for the use of ultrasounds, we can use them. Of course, it is all the more the case when we have tried to get the ultrasounds out of the diagnosis. It can be used by any doctor. The point-of-care ultrasound is now available. It is what we call in Spanish ecografía clínica, clinical ultrasound, point-of-care ultrasound in English. So it facilitates the decision-making in the triage state, and this can be performed by any doctor in the ER, in the ICU. It is accessible by all doctors because the ultrasound systems are available everywhere in hospital. So the main goals of POCUs in PE include the assessment of global cardiac systolic function, the identification of marked right ventricular and left ventricular enlargement, and for the intravascular volume status. And this is all the result of a large paper, a large study published in 2004 that gave as a result the FATE protocol, electroechocardiography for important pathologies. And one of the main pathologies were the changes in the right atrium, massive pulmonary embolism. So we can use the POCUS versus comprehensive echocardiography in pulmonary embolism. This is possible, we know it, but is it safe? Well, 2 papers have been published for the ICU and the emergency room, and they show that it is safe and good. It can also be better than the brain natriuretic peptide or troponin or even the CT without a specific protocol, if it's not an angio CT. We can see it on table 2 in this paper when there was no type of, there was no alteration on the left, on the right atrium. No alteration was visible, this sensitivity is 100% and specificity is 99%. And it is well ahead of the other methods. What about the ICU? It is going to be, well, it was published very recently in September 2017 at the Mount Sinai Hospital in New York. It compared POCUS versus the comprehensive echocardiography in PE, both for senior ICU doctors and for junior ones, and they are at the same level. So the sensitivity is very high, very good, close to 100%. Specificity is also very good. So it is a technique that can be very useful, and especially for doctors that are adequately trained. So the role of POCUS in patients with suspected massive pulmonary embolism is to prioritize over other testing, especially if we are assessing the cost effectiveness after differential diagnosis assessments and assist with treatment decisions in conditions with possible complications. Especially this is the case with patients with a circulatory failure or shocks. It is part of the definition of that hemodynamic instability. So we will be looking for an acute clot pulmonale, embolus in transit, thrombus entrapped in the valves, and also, of course, the presence of deep vein thrombosis and foci, where there is a focus that is present or that has migrated but left some kind of mark, and also in fibrinolysis. If we have all these indications, we can be happy with the effects or with the symptoms or with the signs identified by the ultrasound. We can diagnose an embolism that can be fatal. If there is just an acute respiratory failure, we cannot say that POCUS is not useful. We can identify the A-line pattern, meaning some horizontal lines and scarce mobility of the pleura. If that has already taken place, because when we see a massive pulmonary embolism, it means that it's been there for 24 hours, throwing emboli to the blood, and in that case we can use the ultrasounds even if there is no embolism that produces instability, and we can use it for therapeutic reasons. And these are my last 3 slides. So this is the ultrasound device. This is an ICU bed, but it can also be a box in the emergency room, and we are assessing a patient that has instability and suspected embolism. So we compare the images, and we see that the pleura has less mobility in the affected area than in the healthy area. This is between the ribs, and this is clearly moving very much. And we see that these A lines, these horizontal reverberation lines, are more frequent and visible in this side. And here in this side we can see some vertical B lines that are not visible in the affected area, because it's interstitial lines, so they're not getting any blood, and that's why we cannot see them. Sometimes we can even identify an infarctus that took place the day before, because it continued to throw little emboli, and we see a drop, and we can see this consolidation, this image of echogenicity, and this triangle that is characteristic, and we can even see some bronchioles. If with the same probe, this is a linear probe that we used for these 3 images, low resolution. If we put it near the groin, we'll see this thrombus in the femoral vein that is preventing the flow from getting there. it is a very low flow, and it can be the focus, the origin of the embolism. At a cardiovascular level, we can see that the heart is, in the beginning, the ventricle is not functional well, the vein is dilating and it can create a dysfunction with the McConnell sign. We can see it clearly here, a pathognomonic sign, and we can see the movement that is opposite to the direction of the right ventricle. We see that the left atrium is suffering, the septum is being displaced, we can see a diastolic dysfunction, but then we can see an inversion of the movement of the septum because the septum is occupying the chamber and is compromising the systolic function. So this right ventricle is not functioning well, the left one is beginning to dysfunctioning, so we can start to work. And in a patient with a cardiac arrest and is now recovering from it, we can see this, the left ventricle is this, it reminds us of a womb because it is not being sufficiently, it is not receiving enough blood because it is obstructed. This is a massive pulmonary embolism, a generalized one, and we can see that the circulation on the right side is having a deleterious effect on the left side. This patient has been intervened after a cardiac arrest and the prognosis is very bad. If we detect it here, it's okay, but if we detect it here, there's not much we can do for the patient. Well, so these are my conclusions. I hope you've seen it very clearly in the images. So I would just conclude by saying that the ultrasound is useful for diagnostic evaluation of pulmonary embolism. It's a facilitator for clinical evaluation of pulmonary embolism. It is highly accurate if we compare it with a comprehensive echocardiography, and it is unquestionable for massive pulmonary embolism. There is no excuse unless we don't have an ultrasound device, of course. Thank you.